breast cancer survivor. Oh my God, this is the first time I say it.
Good morning. I am Edibaldo Silva. I'm a surgical oncologist at the Fred and Pamela Buffett Cancer Center of the Nebraska Medical Center in Omaha. And today we are going to look at considerations for the preoperative therapy to optimize care of women with HER2 positive breast cancer. And as part of that, we are going to look at opportunities for enhancing the neoadjuvant therapy of these patients. We all know that preoperative chemotherapy is not new. It has been around for quite some time. Initially, in 2006, it received a national recommendation for its consideration in the treatment of patients who otherwise were eligible to undergo adjuvant chemotherapy. However, starting with NSABP B18 and B27, the most important findings of that study showed that the absence of residual tumor after the use of preoperative chemotherapy in the breast and the axilla was in fact associated with some clinical benefit in breast cancer patients. The problem was that we were not able to identify specifically how to isolate those individuals who would benefit in anticipation of the use of neoadjuvant chemotherapy. However, we have many trials that clearly showed that if you do not look at specific subsets and you treat all individuals eligible equally, it is difficult to show a significant benefit in survival or disease-free survival in patients treated with neoadjuvant chemotherapy. However, there is no question that regardless of the response to chemotherapy, there are significant advantages to be gained by the consideration of using of neoadjuvant chemotherapy in the patient who is otherwise eligible for adjuvant chemotherapy. And although the debate regarding which subtypes may best benefit from the use of neoadjuvant chemotherapy is ongoing, there are clearly a number of established findings that apply to those patients in whom neoadjuvant chemotherapy is offered to. From the beginning, when Dr. Mamunas completed the analysis of B18 and B27, it was very clear that many women who presented with locally advanced breast cancer, who would have only been candidates for mastectomy, were downstaged with the use of preoperative chemotherapy and were able to then undergo breast-conserving surgery. More recently, a group from Yale showed that even in women who were theoretically eligible for breast-conserving surgery, that is, they did not have locally large tumors or significant regional disease, even smaller tumors benefited from the use of preoperative chemotherapy simply because it decreased the rate of margin-positive disease at the time of lumpectomy. And it turns out that's a very important finding, because we know that nationally, nearly 50% of the women who wish to undergo breast conservation who have positive margins at the time of their first attempt at lumpectomy will go on to undergo a mastectomy as their next operation. In fact, Tara King from Memorial Sloan Kettering showed that in younger women under age 50, a positive margin at the time of lumpectomy often leads to the choice by the patient of a bilateral mastectomy. There's no question that we now know that patients who start with axillary disease that is either clinically palpable or documentable by radiologic means can have their lymph nodes once again downstage to a node negative status when they do undergo surgery after completing a full course of preoperative or neoadjuvant chemotherapy. But in our practice, particularly in Omaha, where we are able to work with many women who are seeing Dr. Lynch, Henry Lynch, for their high-risk status, we need time to counsel those individuals. All of them, nearly all of them I should say, are premenopausal, at high risk for being genetic carriers of a potential BRCA predisposition. These individuals take time to undergo genetic counseling, to undergo an evaluation for their BRCA predisposition, and to see medical and gynecologic oncologists, not to mention the plastic surgeons, if they are to consider risk-reducing surgery such as bilateral mastectomy and bilateral prophylactic oophorectomy. So the time that we can treat those patients with neoadjuvant therapy allows us to undergo all these other ancillary but important investigations, so that when the patient has completed the neoadjuvant therapy, they are then able to make an informed decision, knowing that they're not gene carriers, that they can undergo breast conservation, but if they were gene carriers, they can then still go ahead and undergo bilateral nipple skin parent mastectomy, for example. In those patients who undergo nipple skin sperm mastectomy, chemotherapy is very, very instrumental in eliminating the risk of residual tumor that may cause them to have a less than perfect cosmetic result. Obviously, more recently, 2 or 3 large studies worldwide have looked at the use of the patient as their own laboratory, and you can follow the response to the chemotherapy by literally watching these tumors shrink while the patients are being treated. To that extent, we find that many patients, particularly patients with high-risk lesions that are palpable, can actually detect within 2 or 3 cycles of chemotherapy the lack of the tumor growth. In fact, in most patients, after 2 or 3 cycles, the patients come back quite pleased because the tumor is shrinking before their very eyes. These patients, it has been shown, are much more compliant and much more likely to complete their entire course of chemotherapy, regardless of the associated difficulties they may have, such as hair loss and nausea and vomiting and the like. So the use of a chemotherapy regimen that can prove to the patient a priori that the chemo they chose is working is a very, very instrumental in encouraging those patients to complete the entire course of chemotherapy, which in some cases may be an entire year. Now, the use of neoadjuvant chemotherapy has been criticized by many because until recently we had limited ways in which to truly stage the patient from the standpoint of assessing the lymph nodes in the armpit, for example, or assessing the actual extent of the primary tumor. But improvements in radiologic workup have clearly shown that it's possible to adequately stage most of these patients without having to examine the axilla, for example, pathologically. And so nowadays, we need to be a little bit more thoughtful and embark on a more thorough examination of the patient. However, one of the things that is most vexing in the US is that in states like Maine, for example, where Dr. David Craig practices, and in Florida, as many as 1/3 of women in the state with breast cancer undergo an excisional biopsy, that is a removal of the breast tumor to make a diagnosis. We know that, first of all, that should never be done, that core biopsy is the primary approach to these patients. But unfortunately, in a patient in whom the tumor is removed for diagnostic purposes, the entire potential for the patient to undergo preoperative neoadjuvant chemotherapy is eliminated because the primary tumor is now removed, and therefore the patient cannot be likely a candidate to see to what extent the adjuvant chemotherapy in the preoperative setting will be useful for them. So we want to make sure that all of the practicing physicians realize that an excisional biopsy is not any longer acceptable in the management of breast cancer patients. We do also obtain tissue from a core biopsy, which is important that we collaborate with our radiologists because they have to obtain enough cores to be able to provide adequate tissue for genetic expression signatures, for example, the Oncotype DX or MammaPrint. And of course, also we want to be able to do this beforehand because following the completion of preoperative chemotherapy, there may be no further cancer left for the pathologist to be able to assess. To that end, historically we've used mammography for the radiologic staging or diagnostic workup of the patient. We have added ultrasound, obviously, to exactly measure the size of these tumors. But recently, ultrasound has also been used to assess the axilla. So patients in whom the ultrasound shows abnormal axillary nodes can undergo an ultrasound-guided fine needle or core biopsy and establish the presence or absence of axillary metastases. In this setting, clearly, the patient is even more likely to be a candidate for adjuvant chemotherapy, and furthermore, in this setting, they would be a very good candidate for preoperative neoadjuvant chemotherapy. The use of MRI has been around for quite some time. It's been rarely used to assess anything other than the primary presence of a tumor in the breast, and that has always been quite controversial. More recently, a group of investigators have shown that in a small set of patients, the use of MRI before and after chemotherapy can in fact give us some idea of the response of the tumor to the neoadjuvant treatment. Whether it's better than ultrasound, it's not clear, but clearly the use of MRI may be resurgent in this setting. Interestingly, for cost effectiveness, certainly, we are inclined to do less in terms of radiologic staging because we know that a patient with stage 1 breast cancer has a very, very small chance, 0.2%, of harboring metastatic disease. A patient with stage 2 has 1.8% chances of harboring metastatic disease, and only when you get to stage 3 does the radiologic workup reveal about an 8% chance that you may find metastatic disease in these patients. Furthermore, the use of these radiologic exams in all patients is not cost effective. This slide is included only to demonstrate the remarkable difficulties that we have when we routinely use, not selectively, but when we routinely use MRI and mammography. You can see that Ted Tuttle's group, for example, in Minnesota and many others, have shown that when patients embark on MRI as an adjunct to mammography, we have a number of significant problems. The MRI is known to find many other areas of concern that may scare the patient into undergoing a mastectomy when that was not necessary. Many patients who have an MRI, still without any abnormalities, are worried that the doctor is looking for a second problem and are not quite sure why they're doing that, and therefore decide, I think I'll just have a mastectomy instead of breast conservation. And lastly, of course, the MRI can help to exclude very small numbers of patients in whom a second primary may be detectable that may have been missed by the mammogram, and that second primary has to be biopsy proven before a decision is made to undergo a mastectomy instead of breast conservation, because many of these MRI findings unfortunately turn out to be benign. So as far as the axilla, we've already mentioned that the ultrasound is very useful. MRI can also identify abnormal axillary ultrasounds. However, for quite some time there has been a large controversy regarding the use of sentinel biopsy before the patients begin their neoadjuvant chemotherapy. That is, many clinicians want to know if these patients do have axillary disease or not. However, there is no reason to undertake that, as we now know that in these patients, many of them will have resolution of the axillary nodes with preoperative chemotherapy. The surgical management we've covered. Basically, we like to increase the number of patients who can undergo breast conservation instead of mastectomy. It will help to decrease the margin positive rates for those who undergo breast conservation and thus avoid a second trip to the operating room for margin clearance, in which case many times that may be a mastectomy. It does decrease the odds of finding axillary nodes on sentinel node biopsy, and in that case it really does help patients who do not then have to undergo a completion node dissection, avoid the potential difficulties with lymphedema. Lastly, in a very select patient population, for example, patients who are gene carriers, we know that the potential proximity of tumor to the nipple can eliminate the odds of a patient undergoing a satisfactory nipple skin sparing mastectomy, and the use of preoperative chemotherapy can make most of those patients ready candidates for a much better cosmetic result using that approach. Also, of course, it allows timing for the patient to decide when to undergo the salpingo-oophorectomy if they are gene carriers, because as you know, many of these patients are young women. They may not have any children. Although they may wish to undergo risk reduction mastectomy, knowing that the average age of ovarian cancer onset in the BRCA carrier is 51, they may be able to have their children and then undergo a planned risk-reducing bilateral salpingo-oophorectomy. Unfortunately, all of these advances have brought a number of controversies, the biggest of which is how reliable is the sentinel node biopsy to stage the presence or absence of disease in the axilla. There is a very large controversy regarding the fact that the use of preoperative chemotherapy may eliminate the presence of documentable disease in axillary nodes which may then have affected the choice of post-treatment radiation therapy, certainly post-mastectomy radiation therapy, which can complicate not only the patient's long outcome, but plastic surgeons are very, very leery of using radiation after breast reconstruction, and therefore the staging of the patient beforehand remains very important. And lastly, of course, we need to know that once we have a complete pathologic response, although we suspect the patient will have an improved clinical outcome, we need to obtain all the information we need beforehand, because it may ultimately affect the treatment with radiation therapy. I trust this information will be useful to all of you. Thank you.